In identifying disease progression risk, I look at a few things. I look at the clinical and biochemical signs, biochemical markers that are including thyroglobulin and antithyroglobulin antibodies, or looking at a radiographic appearance of increased tumor burden to the patient, or symptoms that are related to tumor burden like dyspnea, dysphagia, bone pain. I would look at the radiographic progression of the disease as well. A PET scan that shows FDG avid lesions that correlates better with a more aggressive tumor, and if the size of the lesions are increasing over a certain period of time. It typically varies, depends on how aggressive the disease seems to be progressing. So post surgery, I generally do an ultrasound about 3 months out, and then check it again 6 months out from the time that they had radioactive iodine. Ultrasounding a patient every 3 to 6 months is very reasonable and is falling in place with the American Thyroid Association guidelines.
If a patient has either had progression after they've had radioactive iodine, or if they had, clear disease, but then they were given radioactive iodine and there's no uptake, these are patients that I would be monitoring. If they seem like they're not growing very quickly, and often I'll get 2 CT scans 3 months apart, if it seems that it's pretty stable and there's very little change, I'll usually spread that out to about every 6 months. However, if a patient is growing, but I still don't think they're actually needing systemic therapy, I'll keep them at either 6 months or 3 months. I use PET scans lots of times to identify sites of disease when I'm not sure that I know all of the sites of disease. Now, there should be caution here because remember, PET scans will only pick up rapidly growing disease. So it won't pick up sometimes patients who might have a very large tumor burden, but they're growing slowly. So it really is not something that you should use to exclude disease elsewhere. If it's not PET positive, it still is very likely that there's thyroid cancer. It's just more slowly growing. And in fact, the majority of thyroid cancer is growing slowly. So I use a PET scan usually to identify sites of disease where I might be missing it. So like if the thyroglobulin triples, there's something growing quickly, presumably I might be able to find that on a PET scan. But then once I've identified where the new site might be, then I follow everything by CAT scans.
Using thyroglobulin, antithyroglobulin monitoring is more important to me sometimes than using some of the larger scans, only because of cost. It makes it much easier to get some of the scans done only after prior authorizations, but the thyroglobulin levels are more readily available. I typically use ultrasound a lot in my practice. I do my own ultrasounds, and I can find disease sometimes faster than the thyroglobulin is turning, so I can monitor that myself. But the larger, more expensive scans, I do hold off on that. The thyroglobulin levels help you figure out how the disease is progressing, if it's progressing steadily or in a linear fashion, or if it rises then plateaus and rises and plateaus. You know the progression of the disease, and sometimes the burden of disease as well.
There are patients that I'm deferring systemic therapy because they really don't have a big tumor burden. Sometimes these patients, the nodules that I'm monitoring mostly in the neck and the chest seem very stable, but I'm also monitoring their thyroglobulin levels. And it's not uncommon that sometimes what'll happen is the nodules on the CT scans look fairly stable, but then all of a sudden the thyroglobulin levels triple. And when that happens, I would say there's discordance between the biomarker and the CAT scans. And in that case, I need to expand what I'm doing. So I might either consider doing an abdominal pelvis CT and check and see whether or not there might be something in the liver, or I might use a PET scan to try to identify additional sites of disease. It's possible that it's not an uncommon situation when that happens, that it's actually a new bone lesion. And sometimes a PET scan is a good way to pick that up, because I might not be able to figure that out just by doing, pan CAT scanning.